So we're 12 o'clock on the dot. Welcome all to the Point of Care 22870 webinar. Thank you for everyone to attending and registering so far. We've had a lot of interest in this, so this is great to see you all in the room at the moment. We've got around about 50. And also many thanks to our panelists. We've got a few panelists in from UCAS, as well as 2 current accredited customers, which is actually great for us and great for you because we can get some feedback on and perception on that. I'll give a little bit of intro in a moment on those, but the remit of today really is to aim to demystify some of the UCAS processes for accrediting 22870 scopes. We also plan to outline the assessment process and get some insight for 2 of our accredited customers, and really at the end as well, there'll be a Q&A session. First off, we'll be having a long presentation from John Ringrow, who's a Senior Assessment Manager in healthcare within UCAS. Been with us since the transition to UCAS in 2012, but worked with CPA from 2006 and has been managing point of care accreditation for most of that time. A big thank you to Jamie Keegans, who's from the Gateshead Health NHS Foundation Trust. He's been a BMS for over 20 years, first implementing point of care tests in A&E departments, and currently in the middle of a rollout of FBC analysis in the Queen Elizabeth. He has the pleasure of being kept busy outside of work with 2 young children, Alfie's Terrier and Celtic FC. Many comments on football allegiances if you want to put them in. This will be followed up by Dr. Sarah Glover, who's currently a consultant at clinical scientists and clinical lead point of care testing at Harrogate and District. Started at Leeds in 2008, moved through to Bradford, but has been at Harrogate since 2014 and took over the clinical lead role in 2017. Dr. Glover has stated that really point of care is a passion for herself to ensure it's embedded in the patient care pathway and ensuring best outcomes in a cost-effective way. Whilst not leading or assisting or consulting, she's let me know that actually running is a hobby of hers, and as we're both runners, we did kind of align that due to lockdown, we're not at a marathon fit level at the moment. I'm sure plenty of people can empathise with that. And then we've also got 2 other people on the panel today. One is Gilda Stubbs. She's an assessment manager for healthcare and has been so since 2015 and has been managing point of care accreditation for 2 years. And last but not least is Louise Davison, who is a senior assessment manager in healthcare. Once again, moved to UCAS from the CPA days and has been managing point of care accreditation under CPA for at least 13 years. So I'll give some more information on the remit at the end, but throughout now you'll be muted, but there's a Q&A session coming in that we'll be managing in the background. If you could bring those questions in on any points you have, and we'll have that at the end. But first off, we're going to move over to John Ringrow presenting. We'll be then moving on to the 2 customers who'll be presenting, and then we'll have a Q&A session at the end. We're hoping to finish around about 12, but I appreciate that we might run over a little bit, so we really want to make sure we address your questions. So with that in mind, John, I wonder if you could be able to unmute yourself. John, can you hear me?
Okay, try that. Am I unmuted now?
There we go, John. That's fab. Great, bro.
Good. That's fine. Wonderful. And just to confirm, we'll be finishing at 1 o'clock, not 12 o'clock.
Sorry, yeah.
Otherwise,
sorry.
I shall just be going.
It's okay. I had a flux capacitor, and it's fine. Fine.
Okay, if we can go to the first slide, please, Dan. Okay, so good afternoon, everyone, and thank you all for attending this webinar. So for the next 20 minutes or so, quite a few slides with quite a bit of information, which all will be very useful to you. And if you're quite new to this field, it will be a lot of consideration and hopefully will be very helpful to you to go back into your laboratories and to the situations you find yourselves in with point of care, to be able to think about maybe applying for point of care as an add-on to 15189. So we'll just run through a little bit of a history. We'll go for some definitions and standards of what we actually mean by point of care. And then we will look at the assessment process and some clarification around that. We'll deal with a few specific areas of ISO 22870 that you may wish to be considering even before you apply, and certainly during the application and preparation for any assessment, and also where to find any information and where to find some help. So a lot of slides, a lot of it can be found from the UCAS website or through links to other websites and guidance documents. So next slide, please, Dan. Okay, if we have the first bullet, right. So for some definitions then, when we talk about point of care, we are talking about analytical patient testing activities provided within an institution, but performed outside the clinical laboratory itself. So the second sentence is quite an important one there, in that it doesn't require permanent dedicated space for point of care, but instead includes kits, instruments which you can actually carry or transport to the vicinity of the patient for immediate testing at that site. So if we go to the next bullet point, and that is a definition for from ISO 22870 itself, is the testing that is performed near or at the site of a patient with the result leading to a possible change in the care of the patient. So again, the second part of that sentence is the important part for that. So it's at or near the site of the patient with the result leading to possible change in the care of the patient. Next slide, please. So just talking about that near patient testing definitions, there are a few grey areas, and it depends on the facilities and the function, the role of the actual central laboratory. Next bullet. There are some areas of this that we would not at the moment consider. For instance, you have the Mohs clinics, the FNAs, the GUM clinics, not generally considered as point of care or assessed under ISO 22870 at the moment. But on the third bullet point, the INR clinics, depending on the function of these, they're probably considered as point of care and can be assessed under 22870. So the first point and the first reference to this is to actually discuss all of this with your assessment manager. So you will be ISO 15189 accredited if you're thinking of moving to add 22870. So the first point of call will be your assessment manager. Okay, next slides. So the requirements of 22870 apply when POCT is carried out in a hospital, clinic, and by a healthcare organisation providing ambulatory care. And what we would not include at the moment is patient self-testing in a home or a community setting. But elements of the 22870 document could be applicable, and they may be beneficial to those people doing that sort of testing to gain a better understanding. So there are things that could be applied to that. Also, there's an importance of the understanding of the legal responsibilities and legal entity considerations when you're dealing within the primary care setting. And that generally produces most of the discussions at the moment. Next slide, please. So for ISO 22870, there are additional standards that are intended for use by those laboratories that wish to include point of care within their accreditation scope. So there are, we do specify the additional requirements for quality and competence of point of care testing. So this international standard, i.e. 22870, gives the specific requirements applicable to point of care and is intended to be used in conjunction with ISO 15189. So the first parameter there is that there has to be some connection to ISO 15189. Next slide, please. So 22870, it does a year 2016 against it. It was actually revised and republished in November 2016. And that included references to 15189, and those were updated in the new version of ISO 22870. The main accreditation document, as we said, is 15189. So if you are applying for accreditation to 22870, it will be referred to in your accreditation schedule, not on your certificate. There is one caveat that we do make customers aware of at the moment, and we are keeping a close eye on, is that ISO 15189 2012 is under review at the moment. And in the future, ISO 22870, it may be incorporated into 15189. So we're keeping a close eye on that. Our section head, Ben Courtney, is heavily involved in the worldwide update of 15189. So he will be keeping us up to date with any developments in that and how 22870 will be affected. Next slide, please. So if you are thinking of applying for 22870, the main form that we would use in medical laboratories and in healthcare is the AC6 form, and there is a box to tick on there for ISO 22870. So if you are thinking of applying, please remember to tick that box. Now, there is a finite amount of space on the AC6 form, and most applicants for 22870 have found it easier to attach a spreadsheet or additional tables, especially if you're a multi-site organization, you have a lot of different clusters or different delivery points. We detail those on a separate spreadsheet. It makes things a little bit easier. But we do need as always for 15189 and 22870, we need to be accurate with that information because we use the application information when we start to create a schedule of accreditation. So we need to take some care over that, and the applicant needs to take care when they apply. Next slide, please. So on the scope of application, what do you actually put on there? Well, it's entirely up to you. You may want to start with very simple concept, for instance, just using glucose meters or blood gas machines, and then expand with extensions to scope later on. And generally, the customers who are accredited to 22870, they find that has been one of the better ways of doing that, is to start small and then expand on things. So let us know if you want to be assessed or accredited for sampling as well, because that does go on the schedule, and that is recorded on the schedule. Next slide, please. So for pre-assessment, we recommend a pre-assessment, especially if this is your first time going through point of care. The pre-assessment visit, it typically involves the assessment manager plus a technical assessor, and it enables some in-depth discussions with the key staff about the requirements, about your current compliance. Gives us the opportunity to view your documents and your records, and we also take the opportunity to do a very restricted sampling of the scope and a small sample of the sites, the clusters, the delivery points. And it also enables us to have some discussions about scheduling, timings, visit frequencies, and that sort of thing. It's quite important really on this pre-assessment to have some quite in-depth discussions about this, because we want the main assessment clearly to go very well, and we also want to make sure that we have sampled everything that you wish to be accredited for. So the final question really is on the pre-assessment is actually asking, is the applicant ready? That's what we're trying to find out. So there should be a final bullet point on that slide, Dan. And there it is the applicant ready? Okay, next slide, please. So when we are sampling activities, we are using three types of definition. First is the site, which is the trust, the legal entity, the NHS, the trust, the hospital. We then start to talk about clusters where we're breaking things down into wards, clinics, GP surgeries, critical care units, theatres, other facilities like that. And then we go to the final points, which is the delivery point. So you could have an ITU, you could have specific ward locations, labour ward, INR clinics, theatres, etc. So we referred to NHS trusts there. In the devolved nations, that can be referred to as the health boards then, and that will generally be the legal entity. Now ISO 17011, which is the standard that UCAS has to abide by as an accrediting body, does allow us a little bit of flexibility as how we can design the structure of the assessments and how we can ensure that all aspects of the service are covered throughout the accreditation cycle. So that is the importance as well of having this pre-assessment and having a discussion with you, and to review your AC6 and your supplementary documents to make sure that we've got an appropriate sampling of the sites, the clusters, the delivery points. Next slide, please. If we click again, there's just a couple of icons that appear at the bottom of that. The policy for sampling at the initial assessment needs to be worked out, and also we need a sampling regime over the 4-year cycle. So what we need to do is we need to make sure that we review all of the key differences. We need to witness a representative portion of all of the delivery points, the clusters, and if there are any different sites involved. We also need to witness all the key activities at the initial assessment and the different types, as I've said, of the clusters to delivery points. Next slide, please. So the assessment is planned. It's delivered exactly as for any other EUCAS assessment. So there will be some pre-visit activity where there will be a documentation review, there will be assessment activity, and there will be post-assessment activity. We'll provide a visit plan for you. That will generally detail the timetable for the assessment, and it's quite useful to have the assessment manager have some engagement with those who are leading the point of care service and the point of care coordinators, who will help to actually manage what goes on and to make sure that we have access to all of the areas that we need to at the appropriate times, and that there are staff available. Any non-conformities that raised at the assessment are identified, improvement actions agreed, exactly the same as a 15189 assessment. So you will be provided with an executive summary, an IAR, recommendations left with the laboratory, full assessment report will follow, and the submission of evidence normally 12 weeks post-assessment. So that's exactly the same as any other initial assessment. Of course, we are in some different times at the moment, so engaging with us and looking towards possibly using a blended assessment approach with this, and certainly having those discussions with the assessment manager going forward, certainly for the rest of this year, may be one of the things that we need to do. Next slide, please. So in preparation for the assessment, goes without saying that it's very, very useful to actually read and interpret both standards. So we're expecting you to read the standards. We are expecting you to do a gap analysis between the standards and what you have in place, what you don't think you have in place. There will be a quality manual and a quality policy, including policies, procedures for point of care. So we're expecting that to be in place. We're expecting staff familiarity with the point of care processes and procedures. And also, and quite important, this is that there is agreed and defined roles and responsibilities for point of care throughout the organisation. We still go into laboratories sometimes where key staff don't really have that much knowledge of all of the standards or the quality management system. The things are getting better now. Gen 1 is the document that replaces Lab 3, C1, E1, Gen 3 and TPS 51. So that's general information you will probably be aware of with your 15189. And we have released information about the replacement for that document. Next slide, please. So what are we looking for? We're looking for conformance with both standards. We're looking for the competence of the organisation and the staff to manage point of care. And we are also looking for sufficient control and assurance processes to actually manage the risks. So that's in essence what any assessment process will be looking for with any standard, really. Next slide, please. So it's also all about reducing the risk, consideration of the risk, and also in managing risk. If you are thinking about adding to your scope of accreditation through future standards, future versions. Risk also features more in the revision of 15189, of which that process I'd indicated has now started. So those of you lucky folks in 15189 accredited labs will get the opportunity to go through another transition in the future. So you thought the initial transition from CPA to 15189 was quite intense. A couple of years down the line before the final distribution of that standard is released. But the approach will align much more closely with ISO 17025 in terms of risk. So if you want an idea of what the new transition to 15189 will look like, and you can get some hold of some copies of ISO 17025 2006 and compare it with ISO 17025 2017, that will actually give you a good an indication of changes to 15189. But it's not as onerous as it might seem. Next slide, please. So what we'll do is we'll just run through very quickly some specific considerations of 2287 now. The first of these is the legal entity, that it must be clearly defined, and we are expecting a formal agreement if point of care is provided to other organisations. Sometimes if you have one particular trust or you have particular trusts or laboratory services that have merged and one laboratory is providing that service for another, we are expecting very, very clear defined legal entity that takes responsibility for that. The legal entity is also defined via a laboratory direction and laboratory director who must be responsible for those results and responsible for the conformance with the standards. Now, the laboratory director is quite key in all of this and would sit in the management and the groups and how point of care is actually defined within all of these groups. So we have point of care group references. There are two types of group. Generally, one group can fulfill both functions really with these. So we need to find certain responsibilities under the point of care management group. We also need to find and this goes a little bit wider within the actual trust of the organisation itself, to have a steering group that manages point of care, has input into how that's managed across the whole organisation. So it could have representation, not just from the laboratory, but from elsewhere within that organisation. So that's quite important. And also, finally, on that slide, we have technical and process considerations with regard to sampling identification, equipment, the examinations, validation, verification, measurement of uncertainty, calibration, metrological traceability, reagents and consumables, and the accommodation and environment. And for that list of technical and process considerations, I'm sure you will have heard of those and be applying those to 15189. So with any pieces of equipment, processes, same things apply to point of care. Next slide, please. So if we move to external quality assurance, actually, if we're done, if you just reveal all of those bullet points on that slide, and we can talk through them at the same time. Oops, just go back one. That's it. So we're ensuring the quality of the results. So the mechanisms have to be in place as they are for 15189. We'd expect the same for 22870. So we're looking for EQA, we're looking for interlaboratory comparisons, we're looking for multiple sites, clusters, delivery points, how you ensure that the quality of results is the same across all of those sites, the clusters, the delivery points, and how you actually manage the internal quality control across all of this. So this is a key operation that the point of care coordinator would be helping to manage. We're looking for also comparability. So referring back to 15189, specifically clause 5.6.4, a defined means of comparing procedures, equipment and methods used in establishing the comparability of results. So there are a lot of things there to consider around 22870, and it's one of the areas that does sometimes provide a few challenges for point of care coordinators, especially if you have a large number of sites and you have different teams, you have different staff on the locations who are actually doing the particular tests. Next slide, please. So there are some other considerations. We are looking at the quality management system. So we are expecting that requirements of 15189 still apply. We're expecting the quality management point of care to be incorporated within the quality management system. Hence the reason for looking at the quality manual. Point of care processes need to be incorporated into that. We're expecting the report management mechanisms to be quite clear. We're expecting how you manage recording results in patient records, the identity of the person performing the test is recorded, and how that report is distinguished from those reports from a central lab. We're expecting how the IT systems are managed. So 15189 5.10 applies to point of care as well. Your audit mechanisms must cover and must incorporate the point of care activities. Do you have adequate document control, and is that managed at all of the sites, the clusters, the delivery points? Similarly with record control and also with non-conformance management. As for 15189, there may be complaints, user satisfaction, root cause analysis, CAPA processes, change control, all of those things we're expecting to be incorporated within your quality management system. So we've got the quality system, we've got the technical requirements of 2287 as well. Next slide, please. So if you're thinking of applying, communication is the key. Bidirectional, UCAS to lab and lab to UCAS. Your interface is going to be your assessment manager, but there are other things that other sources of information out there to help you understand a little bit more about point of care. First point of call is the UCAS website, but there are other websites, including the European Accreditation ones, the International Laboratory Accreditation, IAF, and also ILAC. So all of those have good sources of information, documentation, references that you can use. Next slide, please. So if you're thinking of applying, in summary, conformance has to be with 15189 and 22870. Preparing thoroughly, including doing a gap analysis so that you understand where there are any potential gaps, and you can probably address those things before we come on site to do a full assessment. You will need the full support from the trust or the organisational management, especially around the groups, the management groups and the steering groups on how you manage point of care. Consider carefully your scope of application, the size of it. Start small and then you can expand to it later, and also consider a pre-assessment, because that's very helpful for you. It's also helpful for us if we are going into an organisation as a new assessment manager that we don't know very much about your point of care setup. We can actually help to understand that. So we do expect you though to do the gap analysis, and we don't do that. So that's one point to bear in mind. Okay, so that is a very quick romp through the things that you need to consider if you are thinking of applying for 22870. So I'll hand back to Dan now, who will introduce our next speaker.
Thank you very much, John. That's fab. So that's a great run through. We've got a few questions in already, but feel free to keep adding those in, which we'll address later. And I'm just now going to go on to Jamie. Are you there, Jamie?
Yeah, hello. Thanks for having me. Thanks to John for the presentation beforehand. So my name's Jamie Keegans. I'm one of the point of care coordinators up in Gateshead, and we cover the South of Tyne pathology services. So that's Sunderland Hospital, Gateshead QE and South Tyneside. But credit for these slides, as it says there, must go to my colleague Trish, who helped us out with this presentation. She's not here today. But if you just want to advance the slide, Dan. And I'll give you a brief introduction to our team and take you through the journey for our UCAS assessment, which started in, I think it was January 2018 to March for the initial assessment, followed by an interim visit in 2019. I'm glad everybody's on mute, because I'd probably getting booed and hissed when they see the size of our team. We always get a lot of comments here. We actually have 14 different members of staff that comprise our team for the point of care service here, which I know sounds a lot, but when you divide it over 3 sites and over the whole time equivalents, it's not as impressive as it first seems. So basically, we were set up of a clinical lead, a technical manager, 2 point of care coordinators, 4 band 6s, 3 band 4s, and 3 band 3s. So that brings with it some great advantages, but also over 3 sites we find we still need some more staff. And we evolved really from where I guess a lot of places are in a similar position, just operating from the main lab, which then, as we consolidated in 2013, really turned into its full sort of capacity as a designated point of care team away from the branches of pathology. And I think really that's what we've got to celebrate. That's where I wanted to start this presentation, is that in itself, that we're now going for our own accreditation, is really recognition that point of care has arrived on the scene, and we're no longer the sort of the poor relation to the main lab. So if you could just advance the slide there, Dan. So as John's alluded to earlier, so it all starts off with the AC6 form that was filled in. Advice, just to echo what he said previously, is this is an opportunity to take a realistic approach and decide which we support 11 platforms up here. So be careful which ones you want to present for your initial assessment, because you need to be confident that any findings can be integrated into your routine work. So if you haven't got the team that you sort of would feel can hold this up once it's in place, then I would maybe question the sort of decision to put everything for assessment immediately, especially when you're dealing with unconnected platforms, because you're going to find that a lot of the findings that come out of them will be heavily involved with audit and things like that. So we did conduct a gap analysis on each platform, and you'll probably scare yourself when you do it, because you'll realise how much work there is to be done. A word of advice would probably be to try and address as much as you can if you've got your your dates for assessment in there, but don't be completely obsessed with kind of cramming in to get things in just for the sake of it. By all means, address any deficiencies or areas of weaknesses, but only if it's done in a consistent way, something that's going to that you can continue doing. We found that we put a lot of work in on the pre-end, and then when your findings come back at the end, you might be changing things anyway. So I think a balance there is probably a good thing. Don't get too scared. Try do the things that you can incorporate into routine use, and just hold your hands up if there's something there that you're not going to get done in time. It's better to leave it than to do a half sort of for the word I want to use, job of it. Okay, so advance the slide, please. So what did it look like in terms of the day? And well, it was over 5 days, so we had 4 assessors covering all the lab sort of disciplines: hematology, biochemistry, and microbiology, and they attended the department over a 5-day period. And in total, we got 44 findings and 3 recommendations on that initial visit, which I believe was the most in pathology. So we were accredited over the same period as the main lab was going for their 15189. And there's always a little bit of inter-laboratory banter, but in a way, yes, we got the most, but fantastic, where it shows you that we're now a recognized branch of laboratory science, and it's a lot harder to control things at point of care than it is in the main lab. So they need to realize that as well. So don't be ashamed of what happens on the other end of this. The breakdown is shown there. So we got 11 individual findings for the urinalysis platform, which, as I mentioned earlier, is an unconnected platform. So is very prone to needing a fair bit of work post assessment. 4 managerial, 2 quality management ones. A little point there that the quality management side of things was John sat down with our quality manager and went through our QPulse documents while we were taking the sort of the discipline specific inspectors out around the routine day to day. So your quality management system will get a sort of an examination as well. 14 over the biochemical systems and 16 over hematology. We didn't put our D-dimer ahead for accreditation, and we found that on the initial visit it was very hospital specific. We didn't really go out into the community too much. I can't remember if at all actually. So it was very much looking at the hospital and the 7 hospital sites that we kind of provide support for. We have 125 locations and over 6,000 operators, so it's a big job. If you'd advance the slide, please, Dan. So the schedule was drawn up, which takes a bit of planning, to be honest, because as John's mentioned previously, UCAS are going to want to look at your delivery points. So you need to be liaising with your ward managers and clinic managers as to when's a suitable time to pop in and obviously have the access agreed beforehand. It's also a good opportunity to to really have a look at the wards and see what needs some attention before the visit, so we found that very useful as well. The way that we decided to run it was to give the assessors a proper, true picture of how the point of care team works. So what would happen is the assessors would come in the morning, we would meet for a pre-meeting as a senior team, and then we would take them over to the BMSs who were then shadowed for the day or for the clinic that they were introducing them to, so that they got a good flavour of how the departments really run. If the BMSs couldn't provide the information required, we always had a post day meeting at the end of the day to wrap things up, and any questions the assessors had could be answered by the senior team at that point. And obviously it's quite a challenge when the point of care service still has to continue. So it's a busy environment, but the assessors have all been there and done that. They've got the experience, they know the stresses and strains you're under anyway, and we found that they were really patient and accommodating right throughout the 5 days. Okay, advanced slide. So I'm just going to run through the main findings that we had on the initial assessment. I won't go into massive detail on each one. There was kind of 6. So we found that the first assessment, a lot of the findings were, obviously it's your first opportunity to be assessed. So a lot of the findings were cross-platform, and of course temperature monitoring featured heavily in that. I don't want to scare people off with temperature monitoring, because obviously it's something that is always going to provide a challenge at the point of care, and it's something that we're going to have to target over future years more and more. But I don't think UCAS are expecting perfection, so don't get obsessed with temperature control. But I would advise everyone to start thinking hard about it, particularly if they're in the middle of tenders currently, where you're looking into provision of equipment, gas machines. Does your ward that it's going into have adequate provision for consumables, etc. Temperature monitoring. We've kind of got a halfway house arrangement with Celsius monitors and manual sheets. So we'll have roaming Bluetooth monitors that go out, but unfortunately they only communicate over a certain range, so they all have to come into the hub to download the information. So as long as you have done like a risk assessment of your delivery points, and you can provide this information, it's certainly nothing to be afraid of. UCAS are just looking to see that you've identified these areas and there's some kind of plan in place to help mitigate any risks. You may have to link in with your estates just to identify hotspots within the hospitals and all. You know, we have 7 sites, so a lot of them were quite new to us in a way. We're only just getting that joined up information to see how temperature fluctuates between these sites over the course of a year, especially at Sunderland and South Tyneside, who were hospitals that came into us sort of later on in the day. Training was an area that was picked up. Third-party training, the assessing the quality of it. So basically, on the back of this, we've now introduced audits where we will actually attend the third-party training on a scheduled basis and just assess the trainer, making sure that they're including the material that we want in there. And we feed that back to their company, as well as making it all visible on our quality management systems as well. Our competencies, excuse me, we're a little bit light on evidence, so we've had to build in, you know, banks of questions just to be able to demonstrate that there truly is, you know, somebody achieving competency attached to this, and not just yes, they can do this. You know, they're answering questions now when we're busy trying to make sure that there's an alignment between the assessment and the e-learning platforms that we operate. And verification came up, so making sure that all your platforms have a verification in place, or a re-verification if it's getting a bit dated. I think it was 4 years that we decided on for re-verifications, and then leading on to comparability of results. So we've done a fair bit of work in this area. So just trying to give assurance within and between platforms that, you know, the result that you get in is comparable to a result if you're using, you know, either the lab or a different platform, with a good example being the hemoglobins. You know, we're checking hemoglobin on a HemaQ versus the gas versus the full blood count that we have up in A&E in the QE. Comparability also crept into our EQA schemes. So because of the size of the EQA glucose task, we used to divide it amongst the hospitals. So every month a different hospital site would get their glucose EQA. We've now had to kind of line that up so they all receive it at a reduced frequency, but at the same time, so that we can get that cross comparison of result. And we've found that that's working really well and has given us a lot more data to be used constructively. One of the areas that has got a lot of work is the evidence of return to use or installations. So where your teams are going up to put new meters in, or new platforms as well, we've had to develop, you know, this is where the concept of change control has really been embraced by the department. So you know, if an engineer comes to visit, they've now got forms to fill in where we can prove that when they've left, what work they've done, what QCs they've ran, is the meter fit for purpose, has it been accepted back into use. So we've done a lot of work there. And lastly, on the generic, so the first assessment is the information that came out, just how much information is held away from our quality management system. So our computers, our Y drive, as we call it, contains a lot of information, spreadsheets, it's like the heartbeat of our sort of team. But also, we've now realized after inspection that it contains a lot of information that really should be on the quality management system as well. So we're working hard to sort of make improvements there. So if you just advance the slide there, Dan. This one is mainly about ambient temperature monitoring, so I'm not going to crunch too much into that, Dan. Just go on one again. This is just how we came to a solution for temperature, which is still a work in progress, really. It's takes a lot of resource out of the team, these roaming probes. So I'm going to skip another one, please, Dan. I'm not going to go on too much there. And again. Okay, so measurement of uncertainty came in on the back of really the interim visit. So we're much more aware of it now, building it into our verifications and starting to use our IQC data better and trending, etc. If you just go on again. So the 2019 interim visit, you've already built up a relationship with UCAS at this point. So yeah, it went really smoothly. We certainly weren't fearing it, and maybe as we were the initial assessment. The assessors were fantastic. So on this visit, they're looking to sort of see that you've incorporated the findings of the previous visit into your routine, so that you'll be asked for evidence of that or reasons why you can't provide the evidence. But we found that the interim visit was where there was a bit more scope to look within platforms. So then we're talking things about test lot verification, evidence between platforms, measurement of uncertainty, and evidence of the audits that had taken place against the findings of the initial assessment. In particular, where UCAS were keen is to see action on the back end of a finding. So, okay, you may have come across some poor performance issues within your scope on the first visit, and you've informed the user of this as part of your response to findings. But UCAS really wanted to see what happened next. What did the manager of that ward do in response to that? Where did you collate that evidence? Was there some substance coming out of that initial finding? So follow-up of communications between wards, between the point of care department and the ward managers was featured quite heavily. So just move it on one, Dan. Yeah, I think I've mentioned everything there. So there's some more specifics there. So we introduced IQC, tri-level IQC regimes for the full blood count and analyzers. It was more within platform findings for the interim one. And just to conclude from me, I'd like to talk a little bit about the benefits of the UCAS sort of experience for us and how we found that it's helped us. In particular, if you're a small team wishing to grow, it really does define what actually needs doing out there versus maybe some stuff that's happening that isn't really, providing a function. So you'll find you'll be able to define job roles a lot clearer through it, and that might help you with when you're creating posts, because obviously you still have to marry up who is doing the tasks. I think at the moment a lot of teams are sort of just grateful to have any kind of resource to help, but obviously we still need to ensure that jobs that are done at a certain level, it's carried over into POCT. If something, if somebody can't do something in the laboratory, then that applies to point of care as well, and that may influence some of your job building exercises that are going on. We've mentioned previously about tenders, how the UCAS experience has really helped us put more detail into tenders and know exactly what we need out from the supplier rather than being sort of caught short. And it gives you a bit of leverage both within your pathology department and the hospital. If you've got and that's good or bad. If you've got a platform that isn't performing particularly well, then the fact that it's struggling to attain a UCAS accreditation could be used positively to bring about a change a bit quicker. So bear that in mind as well. You don't have to just present all the golden platforms. The continuous cycle of improvement is just ingrained in us now. So that stigma of inspection that we maybe's got with CPA has certainly gone. It's just part of the routine now. You know that you're going to be continually assessed, and it's not as daunting as it first was. And we've been able to develop that relationship with UCAS over time. and it's enabled us really to self-regulate a bit better. So I think a classic example of this is the change control process that we've now introduced, where we, you know, it's such a dynamic work area, point of care. To really introduce change control, it helps us just get a breath. And make sure that all the evidence is there before something goes live. You know, we've got such heavy IT involvement now. The days of just being able to issue meters here, there and everywhere are truly gone, and it's a lot more controlled. And really, finally, just recognition. As I said earlier, it's recognition that point of care has arrived as a serious branch of pathology testing, and we found that we've got a bigger profile as a result of UCAS, and we've been able to sort of elevate that within the quality management committee of pathology. So when they're incorporating their work, they're much more aware of point of care and how it affects us as well. So all in all, to conclude, you know, don't be afraid of it. Start the process, start it small if necessary, but I think you'll really reap the benefits. Thank you very much.
Thank you for that, Jamie. We've run over a little bit, but I think there's plenty of great information there, so thanks for that, Jamie. What we're going to do now then is move straight on to Sarah, but thank you for your questions so far. We'll come to the end. Some of them we'll have to take offline, as you appreciated, but yeah, we'll carry on with Sarah now. Hi there, Sarah. Yeah,
Hi, John. Thank you very much.
Thank you.
Good afternoon, everyone. Thank you very much for the opportunity to speak about our experience of achieving UCAS accreditation here at Harrogate. I'm Dr. Sarah Glover. I'm a consultant clinical biochemist, and part of that role is being the clinical lead for point of care testing. Next slide, please. So just to briefly run through what I'm going to talk about, I'm just going to give you a little bit of background around our services here at Harrogate, our accreditation history, the application process and the scope of our assessment that we initially put in for UCAS assessment, the assessment process itself and some of its challenges, some of the key issues that came out of that assessment process and how we've improved as a service and the quality of that service through having UCAS ISO accreditation as a service. Next, please. So just to give you a little bit of background about who we are and where we are. So we are a district hospital in North Yorkshire, north of Leeds and west of York. Next, please. So we have 2 hospital sites under the umbrella of Harrogate and District NHS Foundation Trust. So we've the main Harrogate District Hospital site, and then we've a smaller site around 10 miles north of Harrogate, which is Ripon Community Hospital. Next, please. So in addition to those 2 hospital sites, we've got point of care testing at various outreach clinics within North Leeds, Wetherby and Otley, and within the community, within our integrated care teams and some of the North Yorkshire dental services. So we are, as I say, we are a district hospital, but in terms of actual area covered, we have a very, very widespread, far-reaching community services all the way up to Darlington in some cases, and all throughout sort of the North Yorkshire moors and the North Yorkshire area. So we, in terms of community services, we have quite a large spread. Next, please. So in terms of the actual point of care department here at the hospital, we are considerably smaller than what Jamie's got. So we are a sub-department of blood sciences, and we have 1.2 whole-time equivalents of Band 7 point of care manager, and we have 2 whole-time equivalents of Band 3 practitioners, and then a small portion of my time as clinical lead for the service. Next, please. So just to briefly walk you through our accreditation history. So this goes all the way back to 2007, when we were initially accredited to the CPA standards as part of the biochemistry service. In 2011, we then went on to be accredited to the point of care specific CPA standards, and we maintained that accreditation right through to January 2015. And in January 2015, our blood sciences department went through the UCAS assessment to ISO 15189 and obtained their accreditation, at which point we started to look into switching over to ISO accreditation for the point of care service, and we had our initial assessment in March 2016. And since then we've had 3 surveillance visits and 1 full visit. The last full visit was completed last year, so we've actually been through 1 complete cycle, having had ISO accreditation. And some of those additional visits, surveillance visits, we've included some extensions to scope for our service as well. Next, please. So I'll just briefly talk through this. I think Jamie and John have both talked through this really, but the scope is defined very much by yourself. So you can pick and choose which specific devices, which locations, and which service users you actually want to include at any point in time. We didn't have a pre-assessment visit primarily due to our history of CPA accreditation, but John spoke through that quite in a detailed way, and I would definitely recommend most people going through that process to look at where they are and assess whether or not they're ready to go for this. Obviously, the gap analysis is the key point in working out where your service is in terms of meeting these standards and what you need to do to address any areas which might not quite meet those standards. And then obviously there's the cost to consider as well. Obviously, the bigger the scope, the bigger the cost will be. So that's just something to bear in mind. Next, please. So which services did we include? So we included quite a range of services, both connected and non-connected services, and across our service delivery points. So we had 5 blood gas analysers, which were all based at wards within the Harrogate hospital site. 1 EPOC blood gas analyser, which is a portable device which our respiratory nurses take out into patients' homes and do the testing out in the community. We also included approximately 60 of the glucose and ketone meters, and these were spread throughout all of our services. And similarly, our urinalyzer, dipstick analysers, which were also spread at the various sites that we have. And then we have 2 Alea Affinion HbA1c meters, which are used at outpatient clinics here at Harrogate. Next, please. So there were a number of smaller services which we decided not to include, and these included the community neo and glucose and ketone meters, which are just the very small palm-sized devices. Our fetal fibronectin meter, which is used within our maternity services, and our coagucheck meter, which is used in endoscopy on a low volume out at one of our outreach clinics. Next, please. So how did we prepare for our UCAS assessment? Obviously, the gap analysis played the biggest part in detailing what we needed to do to prepare. Regular communication with UCAS, having that 2-way conversation, making sure that everybody was involved in what was going on and everybody was aware of what we were trying to do and the timelines involved. And what we found very, very helpful as well was making sure that there was multidisciplinary involvement from everyone involved in delivering point of care here. So that includes pharmacy, who deal with some of our reagent ordering and reagent handling, the suppliers and manufacturers of all of our devices, who were very supportive in our endeavour to get accredited, and at many points in time we asked them many questions, and we asked them for lots of documentation along the way to evidence what was required. And also getting the clinical teams on board as well, in terms of what we were trying to achieve and how we would do that. Next, please. So the initial assessment, the assessment days, this was done as a standalone assessment rather than in conjunction with blood sciences. So we had 2 days with assessors on site. So Louise was our lead assessor for this. As we were the first to go through the process, we had a moderator, Delia, who just sort of walked us all through the transition period from CPA to UCAS ISO standards. And then we had 2 technical assessors on site as well. So each of our subsequent assessments have actually been in conjunction with blood sciences, and more recently we've actually gone pan-pathology with that. So we now have all of our visits across the entire pathology at the same time. And for these subsequent assessments, we've had, again, one lead assessor and one technical assessor, both of which have spent approximately 2 days within the point of care environment. Next, please. So our biggest challenges, Jamie alluded to some of these as well. So in terms of actually having people available to observe, ensuring a user is performing a test at the time of assessment, that can be pretty tricky, obviously with pressures that are going on outside in the clinical environment. Last minute clinic cancellations, time pressures. As I've said, we cover quite a large geographical area, so that meant that there was actually quite a lot of time and quite a considerable number of miles spent driving through North Yorkshire, getting from one location to another. Can you prove what you say? It's all well and good having a policy in place and saying you do something, but if you can't evidence that, you may as well not be doing it. So you need to have the evidence to back up what you're saying you do. As quite a small team, actually running the service during the assessment is quite tricky. We usually only have 2 or at the very most 3 members of staff in at any one time. So if you've got one of those who's tied up actually with one of the technical assessors, and then somebody else tied up with the lead assessor who's maybe looking at the quality management side of things, that doesn't leave you a lot of scope to actually deal with the day-to-day job. So that's just something to bear in mind. And just the time taken for the assessor to understand the service. So obviously at the moment, UCAS assessment in terms of point of care is relatively new. There's a huge scope of point of care out there, and not all assessors will be familiar with the sort of equipment that you have or the setup that you have within your hospital. So it does take some time for them to learn that and then sort of appreciate what it is that you're doing within your service. Next, please. So the key issues that sort of fell out primarily from our initial visit were training. So providing evidence of competency, not just sort of theoretical competency, but actually practical competency to perform the task. And also the professional responsibilities of users. So making sure that they're up to date with their mandatory training, information governance, data confidentiality, that sort of thing that we needed to assure ourselves of. And then also looking at the sample collection side of things. So it's not necessarily just about the sample processing, it's about the full end-to-end process. Verification is obviously a key part of the standards. Some of the areas we needed to go back and have a little look at in more detail were the comparability between our individual point of care devices. So ensuring that the glucose meter on A&E is exactly the same in terms of analytical results as on any other of our wards or clinics. And also looking at in-house quality control ranges, so using third-party QC, but where possible developing your own ranges to tighten these. And then also verifying the various IT processes that you've got in place. So where you've got data transfer or remote connectivity, actually verifying that it's doing what you think it is doing and checking that. And then Jamie spoke as well about the increase in the volume and scope of audit. That's definitely not to be underestimated, and just something to bear in mind in terms of whether or not you can manage that going forwards, and whether you might think about what to include in your scope initially, bearing in mind that you've got to continue all those processes as you move forward. Next, please. Just defining clear roles and responsibilities for everyone involved, especially in the procurement of services. Who owns the results and what happens to those results, and also who is responsible for that, requesting those tests. Another couple of areas that we needed just to sort of shore up our evidence was really in demonstrating the competency of our actual point of care staff, and in multidisciplinary decision making across the trust. Next, please. So having been through the process and having been accredited for a number of years now, how have we improved? So we've benchmarked the quality of our service. Not all of our service areas are accredited. However, we apply the ISO standards to all areas of our service. So that means that generally across the board, the quality of all of our services is the same or very similar where possible. It demonstrates clinical and cost effectiveness to the trust, and it ensures value for money for the trust. It also gives a really clear signal to our users of their responsibilities, and in taking point of care seriously, it highlights their responsibilities. We've also become much more efficient as a team. We're now much less reactive and much more proactive. So as we've increased the number of audits and ironed out non-conformances, responded to incidences, we now find that although we're doing lots more audits, we're actually not finding issues very often, which is really reassuring that the things we've put in place are effective, and we can ensure the quality of our service. Next, please. So just in summary, UCAS accreditation for point of care testing, it's not an easy task by any means, but it certainly is achievable, especially when you are in control of the scale and what you want to include in the scope. The standards provide a really, really good template to work towards in terms of developing a quality service. So even if you're not at a position at this point in time to think that you could apply for and achieve accreditation, I would definitely recommend getting a copy of the standards, looking through those and comparing to your service and looking where you can bring your service in line with those. Which areas of your service will benefit most? If you can pick out sort of some of the areas where applying those standards will benefit most, that can be really beneficial to the quality of the service that you're providing. And there isn't one correct way of achieving the standards. I'm sure the way that we do things differs greatly from Jamie in many ways, and that will be because our services are different, because the size of our team is different. We've got different devices, different clinical teams. There's many ways to meet the standards. It's about looking at the risk assessment, your services, and how you can meet those standards. The assessment isn't looking as to see whether you've done something in a certain way, it's just looking as to how you meet those standards. And finally, just have a look at the standards and consider how you can achieve them. And you might actually be surprised that with sort of incremental small steps, you can actually come a long way in getting somewhere close to achieving those standards. Next slide, please. So just to summarise, I would definitely consider accreditation and how it might work for you, how it can benefit your services, and think about it just a small step at a time. The fact that you can pick and choose the scope means that you can very much just make it a manageable and achievable thing to do. Thank you very much. I'll hand back to you, Jamie. Sorry, Dan.
It's okay, it's fine. As long as I don't call it anything too derogatory, I'm happy with any name. So thank you for that, Sarah. That's absolutely great. I'm always passionate about the NHS. That's my background. So this has been really insightful. We have run over quite a bit, but there's been some really good information in there. We've had some really good questions as well. So what we're going to aim to do, if you need to go, please feel free to. We'll be having this recording, but we're likely going to finish around about 1:15 with some of the questions. So if you've got any more questions, please post them on now. We've had some great ones in. So first off, I'm going to select those as we're going. But I'm wondering, Gilda, I was going to start with you if that's all right. We've got a question here about, a few questions actually around the same theme of what is a gap analysis for point of care testing? And I suppose from your perspective, Gilda, what would you be looking for as a new applicant?
Hello. For the gap analysis, I'd be looking at what you're actually doing and then looking at what the standard asks you to do and just identify those areas that you need to fill in. A lot of them, I think that the panellists, Sarah and Jamie, have alluded to, is around training and competency, making sure that the the training and competency doesn't extend just to the laboratory staff, but to out of your wider control as well, and that you bring those into your processes. And again, I think looking outside of the laboratory as well, and looking at where the different areas are that you might not have as much control over and what you need to do in those. So basically looking at what you're doing and then looking at what else you need to be doing as well. Okay.
Yeah, thank you, Gilda.
Yeah.
I think that's great. Yeah, bro. So I'm wondering now if you can go back to, I know, Sarah, you've only just finished talking, but I wonder if we can ask you, because obviously you're clinical lead for this. We've had kind of a two-part question across two queries, really. So how much interaction do the assessors have with end users within the inpatient, outpatient kind of setting? But I suppose for me, with my information in the background of that, who do you identify as your users, and do the assessors go and talk to these people?
So throughout our experience, prior to each assessment, whoever's been leading, so Louise for most of our assessments, has identified the areas where they want one of our technical assessors or possibly herself to go out and actually observe. So they specified for us, for example, we want to observe somebody running a blood gas analysis on your A&E department and your special care baby unit. And in that way, we take one of the technical assessors down to each of the departments and they do an observational assessment of one of the users running the test. And then obviously at that point in time, they've got the ability to interact and ask them questions about their training, about processing samples. Usually then it's sort of more of a paper-based exercise back at the office in terms of checking competency documents and that sort of thing. In terms of the wider sort of scope, so at times we have had our assessors asking if they could speak to members of our point of care committee, just about how sort of the point of care meetings are run, how decisions are made throughout the trust, and just sort of to get a wider perspective of point of care within the sort of multidisciplinary environment.
Brill, thank you for that, Sarah. So going to go back now to the senior assessment managers, if that's okay, either Louise or John. I'll see who's unmuted, but there's once again, and it's really about the choice of the application, I think. So the first part of the question is, basically, are they able to choose whether it should be included or excluded from scope on top of a 15109 schedule? And then a follow-up part of that is, since point of care testing activity is high risk, why is it non-mandatory to be accredited to 22870? And Louise has got herself unmuted, so I'll pick on you.
I did actually miss the beginning of that question, Tanya.
No way.
You went Martian, but hopefully I caught the gist. Yes, it's absolutely fine to choose what you're going to be accredited to. Of course, there are concerns about what labs are and are not accredited to. It's something that our technical advisory committee discussed quite a lot. It is a concern, but we do ask you to declare on the application form what you're not applying for, and essentially when we do the assessment we tend to kind of ask why and why that's justified and why the risk is low, and obviously we also make sure that we assess how you tell your users once accreditation is granted what is not accredited, and basically how you communicate that, where that information is, and make sure that you make that very clear to your users what isn't accredited. In terms of picking and choosing, of course, we've got not that many accredited organisations to point of care, unfortunately, which is a concern because of the risk. And although we would love to say it's mandatory for you to apply and get accredited to point of care, because of course that would make us lots of money, but obviously more importantly because that would lower the risk. But that's not UCAS's job. We can't mandate what isn't accredited. I know certainly when I've gone to talks with personnel from NHSE, for example, they are very keen to move on to getting point of care much more accredited, and I believe that the NHSE and RCPath KPIs include the necessity to labs to actually declare what isn't accredited within their scope, and if they manage point of care, they should include what point of care isn't accredited when they actually submit that declaration. So yeah, we would love to say you need to be accredited, but unfortunately that's not within our remit.
Yeah, thank you for that, Louise. That's great. Very senior assessment manager response. Thank you for that. So I'm going to go back to, there's some great questions here to our panelists. So what we're going to do is at the end, we will have, I'll collate all these together and we'll get some concise responses so we can actually publish them as almost like a handout for yourselves. So you've got some almost like a frequently asked questions. But really, I was going to go back to Jamie if possible. There's questions around staffing and everything else, but really, it comes down to how do you ensure engagement with the wider trust point of care committee, and is your committee pathology led?
Yeah, I think the committee is one of the sort of the biggest tools in the box. Really, you can really push your profile a lot higher through having an effective committee. So obviously, an imminent inspection is going to be high up on your agenda. I think we meet quarterly for our committee meetings across all the sites. Sorry, Dan, what was the question?
Yeah, so no, really, it's how are you ensuring engagement? What's the kind of tools you use for, because you have a committee, but are people attending? How do you ensure there's communication mechanisms, things like that?
Absolutely, we really pushed the committee. Some of the attendance was poor, and we made a real sort of targeted drive to increase that. And I think involve even, obviously your committee members are going to have people from finance. We're lucky enough to have one of the medical directors in Sunderland attends, so we really get our issues going right to the top, if you like, for action. But also, don't forget your cascade trainers and everything. Include them in your committee. The bigger the relationship you can build with your cascade trainers and your links on the wards, you'll find that you can save yourselves a lot of work by making them feel part of your team. Make sure they come into your committees, that you're meeting with them regularly and not just contacting them when you need something done. So we've got a really effective A&E team at Sunderland and South Tyneside now, where they've really taken to it like a duck to water. They see point of care as part of their role, and they're quite keen to progress and take responsibility for devices as they sort of get added towards. So yeah, it's a really, really essential tool if you haven't got one already, especially if you want to grow your team as well.
Okay, well, thank you for that, Jamie. One last question. We've got some great questions here. Like I said, we'll come back to them. And really going back now to John, if that's right. It's a more of a practical question. And I suspect it's going to come down to the good old UCAS motto of it depends. But we have an analyzer in a side room next to one of our critical pathway wards. Is this environment likely to be considered more hot lab rather than point of care testing?
Okay. Yeah, it's quite common that we find some of these analyzers tucked away on wards. One of the popular places actually to put analyzers can be a sluice room. So even if it's a side ward, it's still classed as a point of care, because if it's situated actually on the ward itself, you're bringing a specimen perhaps from the patient's bedside. You're going to test it there, and then you're then going to take that result back to a clinician to review the results, to put into the patient's notes, rather than having that analyzer situated in a completely different location. So it's still close to the patient, and the analysis is done more or less straight away. So that's kind of where we're going from, and especially in other situations where we'd have, say, an analyzer, maybe a Potchi analyzer, a urine analysis machine, or a blood gas, actually in a side room or in a sluice room. So it would still class as point of care. But I could fall by the one of the usual UCAS definitions of it depends. We'd need to see the environment, and that could even be one of the discussions that we actually have in a pre-assessment. If we go and sample and we have a look and see where certain things are, and have that discussion with you.
Thank you for that, John. And I think, yeah, that kind of ties in what Louise was talking about, that it's definitely an open conversation, and really sometimes it's whether you're choosing to have that on scope, but we probably identify if there was a risk or critical need in that as well. So I could go on all day, but we already run well over, and a few people are now starting to drop off. So much appreciate for those sticking on. We've got a couple more points I just want to run through before we finish up, just to give you the output of the actual webinar. So next stages, recording will be provided via the UCAS web pages. We'll probably send some sort of update on that when that's available, and I'll be exporting the questions and getting a few responses from both the panelists and the UCAS resources. If you've got any queries about the follow-up on the webinar, please contact the communications inbox, or if any training or accreditation queries, please email the trainer at UCAS, because there are some follow-ups on this. Bear with me, next slide. There's plenty more information on our LinkedIn pages. Feel free to search UCAS. I'm the only Daniel Boyland on there. If you want to link with me as well, I'm part of the commercial training team. UCAS website has plenty of news and events listed, not basically where the webinars are. That tends to be where we're locating those at the moment. And we are supporting training events basically on most of our webinars that we're running at the moment. You can find that via our training services pages on the UCAS. We do have a 22870 point of care course in August. It's heavily subscribed at the moment, and we think we've only got one place left, but we are planning to run some more of these in the future. And of course, if you've got any other training needs, please contact us, because we are able to deliver some of our training requirements on site if you've got more questions after this. So thank you all for attending. Thanks to the panelists. That was absolutely fab. I'm so much passion about this. I think it's great what we've done. And thank you all for those who have posted those questions. We'll make sure we get those addressed, and hopefully that'll help some of our other attendees. But apart from that, thank you for your time, and I'll end the recording, and we'll get that sent out to you shortly. Thank you all.